This is the second in a series of presentations specific to additional disorders of the distal limb of the horse. The intent of this presentation is twofold. First, to describe and provide examples of some disorders of the proximal sesamoids, of which you will need to be able to identify the radiographic findings and diagnose the disorder. And second, to provide case-based practice to help you identify abnormalities and apply the knowledge you've learned to determine a diagnosis or develop a prioritized differential list. So let's start with sesamoiditis, which is characterized radiographically by osseous proliferation on the non-articular surfaces of the proximal sesamoid bone. So this is typically around the abaxial margins. Sesamoiditis is typically associated with degenerative change in the suspensory ligament, and the proliferation is really reflective of enthesopathy at the attachment to the proximal sesamoids. The osseous changes reflect chronic changes, and they can be due to previous inactive disease or current active disease. So therefore, ultrasound can be extremely beneficial in assessment of the soft tissue component to look for, current active disease of the soft tissues. And obviously we'll take our clinical findings in account to correlate what we're seeing on the radiographs. The radiographic findings of the affected sesamoid bone usually includes increased opacity or sclerosis and also irregularity of the margins, which is that proliferative change. However, the findings oftentimes include enlarged and increased number of vascular channels and oftentimes radiolucent zones or cyst formation adjacent to the vascular channels. And actually what those radiolucent areas reflect is really a region where there isn't that osseous proliferation. So it's not necessarily that they're abnormal, they just look like they're abnormal adjacent to the proliferation. And then certainly we might identify soft tissue changes because of the suspensory ligament being involved. So a lot of times that would be swelling. This is a very magnified and collimated view of one of the proximal sesamoids, and it is showing both the kind of proliferative change, so the irregularity to the abaxial margin, some overall sclerosis, and then the radiolucent zones that are adjacent to or part of the normal vascular channels. This would be an example of kind of that thin normal vascular channel. So be sure to remind yourself of the normal appearance and anatomy. And then this patient has some soft tissue swelling around that affected bone. And so radiographically, we would say that this patient has sesamoiditis. Here's an example of a patient that we have a lateral view and then the DMPL view and then a close-up view of the affected sesamoid, proximal sesamoid, because one can be affected or both can be affected. On the lateral view, you're not going to be able to say much about either proximal sesamoid because they're superimposed, but we can assess for the kind of palmar soft tissue swelling that is here on this patient. We can see that one of the proximal sesamoids has some changes to it. When we do the DMPL view, now we're looking at that medial proximal sesamoid. There is definitely soft tissue swelling that is surrounding this sesamoid. On the close-up view, we can see that here is that kind of osseous proliferation and remodeling of that abaxial surface, quite a bit of sclerosis, and then some of these smaller cystic lucencies or radiolucent zones that would be potentially enlargement of the vascular channels or just associated with the vascular channels. Remember that the proximal sesamoid doesn't have much of a periosteum, so we don't oftentimes get a lot of periosteal reaction. Here's an example of a patient where I have both oblique views. So we have the lateral view and then the DMPL and the DLPM view. Remember, we have to have that radiographic marker on there to help us determine when we're in the fetlock, what is more medial and what is more lateral. So remember that marker always goes at the more lateral aspect. So this is dorsolateral here, palmar medial. This is dorsal medial and palmar lateral. On the lateral view, mainly I just see some soft tissue swelling, kind of distorting the normal fascial planes. On the view here that we are looking at the medial proximal sesamoid. This is the one that is mildly abnormal compared to this normal lateral proximal sesamoid. So this one has very thin vascular channels and a pretty smooth abaxial margin. So this one has a little bit more remodeling and irregularity to that abaxial margin, has more sclerosis when you compare it to the normal one, has a little bit of enlargement of that vascular channel, and has kind of this subtle radiolucent area. So this patient has sesamoiditis involving just the medial proximal sesamoid. Here's an example of a different patient that I gave you the DP view and then the two oblique views. So on this patient, on the DP view, I just wanted to point out that it can be a little bit more challenging to evaluate the proximal sesamoids. The lateral one here is pretty normal. On the medial one, if you look at this abaxial margin, there are some irregularities and probably some lucencies that we can see, and we'll see those repeated. An area to really assess, because it's hard to assess that on the oblique views, would be the axial region here, because there is a ligament that goes in between the proximal sesamoids, and that can have effects on it as part of the soft tissue swelling, or soft tissue changes and damage, and so we can look for some of the cystic lucencies there. This patient, the medial proximal sesamoid, is the abnormal one, and if we look, there's quite a bit of remodeling and kind of mild proliferation along that abaxial margin. This patient has sclerosis and then has a lot of kind of radiolucent zones, enlargement of vascular channels, or cystic type changes, and then soft tissue swelling associated with it. The lateral proximal sesamoid is actually pretty normal in this patient. Again, sometimes little subtle lucencies might be hard to determine if they're normal or abnormal. And then remember, these findings indicate chronicity, and there may or may not be current active problems. I'm going to touch base briefly on proximal sesamoid fractures, and proximal sesamoid fractures are fairly consistently of three types. They can affect the apical portion, the mid-body, or the basilar portion. If you see wide separation of the sesamoid fragments, that usually indicates disruption of the fibers of the suspensory ligament. And sometimes you might even be able to use stress applied during your radiographs to show that hyperextension of the fetlock is occurring. Special radiographic projections are often needed to detect abaxial fractures, which typically will result from avulsion of bone by a portion of the attachment of the branches of the suspensory ligament. Briefly, the prognosis is correlated to the type of fracture and a damaged to the associated structures, which would include your suspensory ligament and all of the ligaments of the proximal sesamoid bones. And so in these cases, ultrasound is also very important to assess the soft tissues. I just have a couple examples of sesamoid fractures. This horse has a mildly displaced fracture that is an apical fracture of the lateral proximal sesamoid. We can see that there is kind of a mild separation between the apical fragment and the rest of the sesamoid. There is some sclerosis of the margins and rounding of the margins, and so this is a more chronic fracture. And again, we're going to have to look at the patient clinically to determine, how this is affecting this patient, and ultrasound the soft tissues. Here's a patient that has a basilar fracture that is affecting the lateral proximal sesamoid. On the lateral view, we can clearly see a large fragment and probably a couple other smaller fragments. It's going to be hard to determine which sesamoid this is associated with. There is soft tissue swelling along the palmar aspect here, it's the hind limb, so the plantar aspect. On the two oblique views, we can see this fracture on both of them. since this is labeled as this being dorsolateral, this will be palmar medial. So this is the medial proximal sesamoid and this is the lateral proximal sesamoid. And I can see that fracture here along the base of that lateral proximal sesamoid, which is a little bit more challenging to see on the oblique view that better shows us the lateral proximal sesamoid just because it's superimposed over the medial proximal sesamoid. But again, we can see that fracture and those little fragments. Oftentimes, these basilar fractures have a lot more soft tissue damage because that's where all of those sesamoidian ligaments, many of the sesamoidian ligaments, arise along that kind of base of the sesamoids. All right, I'm going to finish out this presentation with doing some practice cases. And again, just looking at more cases and getting lots of practice is going to be what's really important to your feeling comfortable looking at radiographs. So case number 1 is a 15-year-old quarter horse mare who has chronic right thoracic limb lameness. And I have 3 views here for you: the lateral, the 65-degree DPO, and the flexor tangential view of the navicular bone. Probably the 2 images on the right show us the primary findings. When I look at this navicular bone, I see these large cystic kind of lucencies and enlargements and abnormal shapes of the synovial invaginations. When we look at the skyline view, quite a bit of flexor cortical erosion as well as those enlargement of the synovial invaginations, along with medullary sclerosis with poor distinction between the medullary region and the flexor cortex. So quite a few severe changes. A small focus of mineralization is here on the lateral view proximal to the navicular bone, and that may actually be within the suspensory or collateral ligaments of the navicular bone. It's too dorsal to be within the deep digital flexor tendon. I don't see any changes of laminitis in this patient. Very normal distal phalanx, normal parallel cortex to hoof wall, and normal clarity of our hoof soft tissues. So this patient has findings that would be of severe navicular degeneration, and because of the flexor cortical erosions, most likely has navicular disease. But again, we'll clinically correlate that. Case number 2 is a 10-year-old warm blood mare who is lame in the left thoracic limb, and I only have the kind of standard orthogonal views here. On the lateral view, one of the first things that catches my eye is that there is this linear lucency within the dorsal hoof wall. There's also poor distinction between the, laminae here that we talked about before. And then if I look at this dorsal cortex of the distal phalanx relative to the dorsal hoof wall, there is a lack of parallelism there. So this is actually mildly deviated to the palmar aspect or mildly rotated. I also notice this concavity in the region of the coronary band, although the distal phalanx, that extensor process is still fairly similar to the level of the coronary band. It may be a little bit low in that capsule. I don't really see too many other osseous changes. Ideally, we'd have that 65-degree DPO view, which I don't have. So these are findings of chronic laminitis with rotation and suspected early sinking. And again, remember that linear lucency may represent gas that is able to track from it coming up from that white zone. In this case, it may be vacuum phenomenon from nitrous coming in from that vascular system. Case number 3 is a yearling quarter horse that has marked right pelvic limb lameness. These images aren't the greatest quality, but they still show what we need to see. This is a lateral view. This is our 65-degree DPO view, and then this is the navicular skyline view. On the lateral view, this marker is on our dorsal hoof wall, and we can compare the dorsal cortex of the distal phalanx that is in normal alignment. However, I do notice that there is this linear gas that is tracking through the sole. I'm going to come back to this view in a second. On this view in the middle of the slide, when I look at the medial palmar process, there's an abnormality here. I identify this kind of big, lucent, almost geographic area. Seems to be fairly distinctly marginated. When I look within that lucency, I see this very opaque piece of bone that is situated within that lucency. If I go back to the lateral view and look closely, I can actually see it in this lateral view too. So there's this geographic area of lucency, and then within the center is this very opaque piece of bone. On the skyline view of the navicular bone is normal, but I can actually see that area of lucency in the medial plantar, excuse me. I think I said palmar process before, but since we're in the pelvic limb, this would be the plantar process, so medial plantar process. So when I look at these findings would be very consistent with focal septic pedal osteitis with sequestrum formation. So I hope that was running through your mind as we saw that. So we were seeing before focal septic pedal osteitis out along the solar margin, but this is an example where it's happening deeper within the bone. And so at some point there was probably a puncture through that sole, and that's where that gas is coming from. So focal septic pedal osteitis with sequestrum formation. So don't forget to look for those sequestra. Case number 4 is a 9-year-old quarter horse gelding. This is actually a pre-purchase exam. On the pre-purchase exam, the patient had mild left front lameness and positive to hoof tester at the heel. There are kind of the 3 standard views that we would obtain for the distal phalanx and the navicular bone. The lateral view looks pretty normal. I have no changes to the distal phalanx or the hoof wall, normal alignment, so that looks pretty good. On the middle image here, the 65-degree DP view, navicular bone here, I'm not sure I see a whole lot of changes, although out at the kind of medial kind of body extremity, maybe a couple little synovial invaginations that are more focal. I do see this kind of unusual oval lucency here in this medial palmar process that is more distinct and different from the lateral palmar process. And then on the flexor skyline view of the navicular bone, there is a more important abnormality that was challenging to see on any other view. When we look at this medial portion of the navicular bone, there's quite a bit of focal but diffuse medullary sclerosis. These are those little synovial invaginations. And if you notice, there's a radiolucent line traversing from the flexor cortex to the articular surface. And so this is a fracture of that portion of the navicular bone. This is most likely a chronic navicular fracture. And then this region right here is where the collateral ligament inserts of the medial collateral ligament of the distal interphalangeal joint. And so there's probably enthesopathy there that's associated with this chronic navicular fracture. All right, our last case is a 15-year-old thoroughbred gelding who has grade 3 out of 5 acute lameness and is positive to fetlock flexion. There is a lateral view and then both oblique views, and on the lateral view I see quite a bit of soft tissue swelling that is predominantly, extracapsular at the kind of palmar aspect here of the fetlock region. Probably a little bit of intracapsular swelling as well, but predominantly extracapsular. There's kind of an odd appearance to the region of the proximal sesamoids that we're going to have to look at again. And when I look at my 2 oblique views, it looks like the proximal sesamoid over here, which based on our labeling is going to be our medial one, has some kind of lucent zone associated with it, as well as some proliferative remodeling change along that abaxial aspect. I believe it has more sclerosis in it than compared to the much more normal looking lateral proximal sesamoid. It's a few little vascular channels and a pretty normal margin. But I'm going to keep looking closely because there's still this kind of other unusual area. And on this oblique view, we can actually demonstrate much better that there is this radiolucent line that is traversing a portion of that proximal sesamoid all the way to the articular surface, which is actually this line right here. And so this patient actually has a fracture of that proximal sesamoid, that medial proximal sesamoid. There are more chronic changes, so he also has signs of chronic sesamoiditis. And so potentially in this case, we had chronic sesamoiditis, damage to that suspensory ligament, and then this might actually be an acute but pathologic fracture that has occurred on this sesamoid. So that is the conclusion of this presentation, as well as the presentations for the course. Be sure that you consult the textbooks and references here if you want further explanation, and definitely if you want to see additional images, because again, more images, better practice for you.